I'm going to talk to you today about NG, nasogastric suctioning. And we have two that are represented here. There's one. This is the feeding tube, so you don't usually do suction down from the feeding tube. And this is the one you tend to suction with. Now there are several purposes for an NG tube. One is to suction and one is to feed. Let me give you the characteristics of the feeding tube. You see how thin it is? It tends to be more thin, more durable. It's very soft and pliable. It has an X-ray detectable black end, which you can, when you put it down, you can easily see on X-ray to make sure that it's in the right place so they don't aspirate. And also, because it's so flimsy, it has, let me see if I can get this out. It has a guide wire that goes down it. You can see this guide wire right here. I don't know if you can put my paper up. See that wire right there that guides it down. And once it's down and x-rayed, then you can take this guide wire out and dispose of it. But you don't want to put it back in because it'll puncture the edge of the tube. And this is your suction tube. And this thing that's hanging off the side of it is called a pigtail. And this is only an air vent. It's used to connect it to the main tube section. And this allows the main tubing section to work more properly. It allows you to be able to suction out better or to put something in if you need to. So we're going to talk about how to put down an NG tube, either one of these. And first you want your patient in a high Fowler's position. So that means sitting straight up like this. And then you want to look in their nose and see which side is the least deviated. If they're both about the same, you can put it in the side closest to you. And then you're going to get your tube, and it's a clean procedure, and you want to measure. I'll kind of, if you'll hold him over here like that, they can see. I'm going to measure the tip of it is the tip of the nose, back to the ear, down to the xiphoid process. And that will measure to see how far you should put it down. And then once you get it down here, you're going to tape it, so you're going to know how far you've put it down. So we have him in a high Fowler's position. We're going to put it in the side next to me, it's the least deviated. And we've measured from nose to ear to xiphoid process. Now to remember that, you can do it kind of on yourself, but you don't want to put it up next to your skin because the oils of your skin will get it dirty. So you want to kind of put it like that, just in practice, not in real life. But if you are to lift your head up and down, you see that it doesn't move down here. Okay? If you turn it this way, which people forget and do sometimes, if you lift it up and put it down, it changes down here. So you want to make sure that you do it the right way. So now that I've measured and I've taped it off down here, then I'm going to get some lubrication on the very end, and I'm going to have them maybe just hold back their head back just a little bit so I can see to put it down. Just kind of go in right there, and you're going to meet a little bit of resistance. You've got to push past that resistance a little bit. And once you get past that resistance, you're going to have your assistant, another nurse, if they can swallow a little bit or if they can drink, if they're not NPO, to give them water. And every time they take a sip, you're going to push it in, 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 until you get to the taped area. Once you're in that area, then you can have them quit sipping, and you will tape it to the nose. But now that it's in the right area, you are going to check and make sure that it's in the right area. So a couple ways of checking. This is probably the least accurate, but it's a way of checking. You'll see it done in the hospital. You'll get about 30 milliliters of air and get your stethoscope. And you're going to listen to their stomach as you push it in. You get a little swoosh of air. The reason that is the least accurate is because the air is going to go down anyway, so you're probably going to hear it to a degree, even if it isn't totally in the stomach. Another way to check is to put a syringe on and you want to aspirate gastric contents to see if you're in the stomach. If they aren't on continuous suction, go ahead and push the contents back in to promote electrolyte balance. So you just want to check it and see if it's in the right place. And a third way, which we've already mentioned with this feeding tube, is X-ray, and X-ray is best. And actually, if you look on this tube right here, there's a white line, and that's also for X-ray. So we have a person with their NG tube in, and then you can take it and you will hook them up to suction right here. Actually, you'll pull the suction connector out of this and hook it up right here, and then turn on your suction machine. And then it will suction from the patient into the machine. Now, if you have a patient that's on continuous suction and they have a PO, by mouth medication ordered, the obvious thing to do would be to turn the machine off so it wouldn't be suctioning as soon as the medication got down. So if you do that, if you're on continuous suction, you need to get a doctor's order to turn it off or to tell them what's going on. A better thing to do would be give it another route. Call the doctor. Hello, my patient has an NG tube. Can we give this medication by IM injection or by IV or suppository or patch? Another direction, another route would be the better thing to do. A couple other things to tell you on this would be, if you're putting something in the patient, let's say we're going to give them some meds and we pour the meds down here. When you give it to them, that's called gavage, G-A-V-A-G-E. That's gavage, is to give. If you're taking something away from the patient, like if you're suctioning, that's called lavage, L-A-V-A-G-E, lavage, to leave. So to pull out is lavage, to leave, and gavage is to give. One other thing, when you put your tube into your patient, it's going to activate the lacrimal ducts. So a lot of times your patient will look like they're crying when this is going in. It does not feel very comfortable. You also need to establish a wait a minute signal for them to maybe hold their hand up if they just, can't take it, if they need a breather or to take a breath, a pause, have them hold their hand up. And then it's really important to have a basin nearby, because a lot of times when it goes past the gag reflex, some people are super sensitive and they may need to go ahead and throw up. So it's nice to have that handy just in case. Once you get it down, another thing you can do is you can also take your pen light and have them open their mouth and just look in the back of their mouth, and you should be able to see the tube going down in the back of their mouth. When you take the tube out, you need to turn off the suction, obviously, get on a clean pair of gloves, and then just kind of wrap your tube up. And if you want to stabilize this patient here, and you just want to pull it out, just hand over hand like that, and wrap it up in your gloves and dispose of it. So that's your NG. Thank you.
See if you can answer these questions.